Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations and a full extra-sode from Season 3, Episode 16, our discussion on what data modeling can tell us about drug and diagnostic development and patient treatment. The extra-sode is on MRE and Hepatogram and their place in clinical treatment of patients today. This extra-sode discussion lasts just over 30 minutes, and a brief synopsis cannot do it justice. To start, Mazen Noureddin discusses how he came to explore the idea of a MAST score after reading the original FAST score paper. He wondered what would happen if we replaced FibroScan in those computations with MRE plus MRI-PDFF, which provide more precise results. He found several different promising outcomes from working with MAST, which he describes in this conversation. When he finishes, Scott Reeder and Kay Pepin discuss practical and logistical issues related to use of MRE, single breath hold testing, relatively low cost, and availability of MREs outside of clinical trial settings. Stephen Harrison discusses the likely path to FDA acceptance of MRE results in place of biopsy. And finally, the group discusses the importance of analyzing the entire liver, possibly with automated volume estimates in the next 6 to 12 months, instead of the small slice of liver used in biopsy, which can be as little as 1/700,000th of the liver. Louise Campbell adds a couple of her own thoughts about this general topic, and the discussion wraps up with each participant discussing how clinicians should be thinking today about how to integrate MRE or Hepatogram, which is MRE plus PDFF, or even Hepatogram plus LIC, liver iron concentration, into practice. A stimulating set of topics on which to close. As we move beyond the biopsy, MRE and MRI-PDFF, and combined as Hepatogram, will have an increasingly important role to play both in drug development and patient treatment. This information is vitally important for us to understand now. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn and Facebook discussion group. Today, what we're going to be doing is taking a look at MRE, something we talk about a bunch on the podcast, but I don't know that, except for a couple of episodes with Alina Allen, where we talked about predictive ability in drug development and research, I don't know that we've ever devoted an episode to it. I think, Mazen, we've talked about it on a couple episodes with you as well, where we talked a little bit about the cost-effectiveness issues. But what we've never done is taken a look at MRE in terms of a tool for practical patient management in 2022. That would be this year, in the States or really anywhere in the world. That's what we're going to do for the next half hour. We have a fantastic panel of people with us, in addition to Stephen and Louise, who just tend to show up for this and everything else. We have Scott Reeder from the University of Wisconsin. Thanks for joining us. And then from one state over, we have Kay Pepin, who is in Minnesota with Resoundent and Mayo. Okay, why don't we just dive in? What we're going to do today is, as I said, talk a little bit about MRE and its use in practice. But before we do that, if you listen to this podcast, you know Louise, you know Stephen, you know Mazen, you don't know our other 2 guests. So Scott first, then Kay, please take a minute or 2, just tell us a little bit about yourselves, what you do, your work, and end with one fact that we wouldn't know if you didn't tell us.
Scott Reeder.
Sure. Well, I'm a radiologist and I'm also an engineer. So I think a lot about clinical imaging. I think a lot about the nuts and bolts and technology behind imaging as well. I have a interesting, or I should say, a very enjoyable career where I get to work both with patients and referring physicians and also with graduate students, engineers, and physicists as well. So a lot of fun doing translational work, taking imaging all the way to clinical practice. I'm vice chair of research in our department. I'm also our clinical chief of MRI as well. So those are some of the things that I do. And fun thing, well, I'm from Canada originally, so maybe you'll hear my accent come out.
Certainly, when you said Canada, I heard your accent. The heavier D kind of does give you away. Where in Canada are you from?
Originally from Atlantic, Canada as a little boy, and then mostly grew up on the West Coast in British Columbia.
And now you're somewhere in the middle, but a few miles south. Good geographic coverage in North America, Scott. Very, very compelling. Kay, go ahead.
Yeah. Kay Pepin.
I'm Director of Research Translation at Resoundent, and I also hold a joint appointment at Mayo Clinic in the Advanced MRI Laboratory. So my career so far really has focused on imaging biomarkers. It's a topic I'm very passionate about. I did my graduate training in MRE, but actually I was looking at cancer, looking at tumor response to treatment, both chemotherapy and radiation therapy. I then spent a few years in radiation oncology, looking at various imaging biomarkers, both to predict response to treatment and also monitor it. Today, I really focus my efforts on supporting the use of MRE in clinical trials, whether it's the day-to-day applications or through our work with the FDA Biomarker Qualification Program, and then also with KIBA, the Quantitative Imaging Biomarker Alliance. This is a really fantastic organization whose mission is to improve the value and practicality of quantitative imaging biomarkers by reducing variability across devices, sites, patients, and time. So for the random fact about Kay, growing up, I spent several summers picking and selling 1.5 acres of sweet corn. So quite a different job from what I'm doing today.
Stephen Harrison.
Did you ever have to detassel the corn?
Oh, yeah. I learned that a field of corn in August is at least 10 degrees warmer than anywhere else.
I had to learn that. I was selling books door to door in Waterloo, Iowa between my first and second year of college. And I got to learn all about detasseling corn.
People get very passionate about that too. Not quite the same as imaging biomarkers, but
no doubt. That and the smell of pigs in Iowa in the summer. But
sounds about right.
You can tell the difference between people from metropolitan New York and everyone else, because the thing that's hotter than anything, I've never been near Kay, is my first job was actually baking bagels. And trust me, a bagel oven,
that's pretty hot
on a summer day. For those who don't know, it's a double cook process if you're done right, and it can get really hot in the summer when baking bagels. Although it isn't.
Is it as hot as the non-invasive testing market for NASH?
Yeah. Well, and certainly not as hot as it's about to be. How's that? Bagel baking kind of hits a peak and stays there. Non-invasive testing is going to get crazier and crazier. So with that, why don't we launch into today's topic? What we're going to do with the discussion is I've asked Mazen and then Scott and then Kay to take three different perspectives on the question of MRE's role, not in drug development, which we talked about, but day-to-day patient management, efficient testing, and then tests that work and are efficient and are easy to read. And Mazen will talk about some of his work on that. And then Scott from a radiology point of view, and Kay from a more resounding point of view, and a kind of what are the practicalities and logistics of making that happen in 2022. And then we'll do quick Q&A, and then we'll be done. So Mazen, the floor is yours. Take us through your MAST research. Maybe take 5 minutes and take us through. Thank you, sir.
Mazen Noureddin.
Sure. So you'll want me mainly to talk about the MAST paper. I will talk about it. Also, I would like to take the chance to talk about my clinical experience with MRE. I finished fellowship in 2013. I was a fellow with a young faculty by name Rohit Lumba. So we worked together on MRI-PDFF. He started doing MRE research. And then I moved to Los Angeles, and I was a big believer of this technology and what it can provide to the field and the patients, importantly. I don't remember exactly when the FDA approval came about, but I do remember the AGA paper that put MRE as one of the tools to be used to stage patients. And that helped me significantly. Back when I was in San Diego, everyone was saying like PDFF is expensive, MRE is expensive, it's going to be very costly to our system. And I mentioned to Scott earlier that he wrote a paper about the Medicare cost of it and how it can be done as just a limited abdomen test without a contrast and be cost effective. And it's not that expensive if it's tailored well. So I started doing MRE as part of my clinical practice. It has been years now, and the insurance covered it. And I have had a large cohort of MRE patients as I thought it will be approved by insurance. And I did it the same way I'll do it myself. I went and checked myself with PDFF and MRE if I have fatty liver or not. I used it as sequential testing as well after transient elastography. And sometimes I used it as a first tool when I felt the patient will benefit from it immediately rather than just going through other NITs, such as BMI of 40 or so. That will lead to my topic, which is the MAST score that we just published in hepatology, because over the years we collected a large cohort of MRI-PDFF and MRE in labs, and some had biopsy with that they went into clinical trials or clinical practice. So you all are aware of the FAST score, which came out in Lancet Gastrohepatology, and Stephen is part of that work. And basically it is because we found that the F2 patients, they have increased morbidity and mortality. I thought that Stephen and Phil Newsom and other colleagues, they had a great idea to look at that target group in particular for NASH and F2 to look for it non-invasively to qualify for clinical trials, and eventually will be in clinical practice because those are the people that we're going to treat when we have drug approved. So it was a great paper, but when it came out after they presented in the ASLD, I said to myself, well, we have data from UCSD that MRE and PDFF are more accurate than a FibroScan. Why we don't do it a similar way? We don't do similar score based on MRI-PDFF and MRE. And that's how we started. We started with validation cohort. Although we have a lot of MREs, not everyone had a biopsy. So the derivative cohort was about 103 patients from Los Angeles, and they had paired liver biopsy, PDFF, MRE, and labs within a reasonable time frame. I think it was less than 6 months to make sure there's no change in the patient characteristics. And through logistic regression, we looked at the PDFF and MRE were the backbone of that test, but we looked also at other variables that can improve the test. And we wanted to make it simple, and we used the best variable that came out, which was was AST, followed by ALT, and that one. We ended up putting the score, and to our pleasant surprise, the area under the curve from that study, or that first cohort, derivative cohort, came out as 0.6, which was higher than the FAST previous publication. It did also have the MAST score again to detect NASH and F2, other than the great area under the curve. Very good MPV sensitivity, reasonable specificity, and reasonable PPV for the population we studied. I then reached out to Stephen and I asked him to share with me his cohort, which is the well-known cohort that he's recently published, the JHAP prevalence paper. So we used that cohort with the parameters I mentioned, and we validated that MAST score. Stephen was essential to that paper. We had a great input from him and great ideas, and his cohort actually came with a higher area under the curve, 0.93, again with excellent MPV sensitivity, very good specificity and PPV. And then we found that the indeterminate zone was quite narrow, less than 20% for the derivative and validation cohort. So it's out there. It's great to look for patients in NASH and F2. And the last thing I want to say is that we did road testing for longitudinal correlation or longitudinal use of that score. And we used that in the resmetirom. They showed nicely that in the resmetirom group, the score drops nicely. And we know that drug is effective from previous trial. So it has shown that it can be used longitudinally to predict drugs response during clinical trials. The last thing I'll mention, I will stop here, that this score, its MRE plays significant role in it. So some people say, well, it's probably the AST, which we think probably the FAST score is dependent a lot on AST and can change it. No, that score is actually MRE is probably the main driver, followed by PDFF and then AST the least. So with that, I'll stop and let other people talk.
So Mazen, first of all, thanks. That was fantastic. Before we go on to Scott, Stephen, as a participant in some of that, do you have a comment you want to share before we go on to Scott, next part of the presentation?
Yeah, I mean, I think the work Mazen has done on this has been really groundbreaking, and the utilization of the combined PDFF, MRE, and AST to identify the at-risk NASH patient. And just to take it a step further in the work that he's done with resmetirom, it's really validated the fact that in using this score, we can do a very good job of identifying the F2 at-risk NASH patient, so the F2 or greater NASH patient, and good at ruling out those that don't have the disease relative to FAST score, for instance. So more work to do in that regard, but it certainly speaks to the power of the technology and its utilization in the field right now.
We'll come back to that a little bit more broadly in terms of questions and other thoughts around that after we've heard from Scott and from Kay. Scott, your floor.
Scott Reeder.
Well, I've known about MRE for a long time. In fact, I first became acquainted with it back in the 1990s when the seminal paper from the Mayo Clinic came out. I was a graduate student at the time, and one of my mentors was really mad about it because he thought this was such a great idea that he wished he had thought of it. And so it's something that I've paid attention to for a long time, but then it really, in my mind, gained traction around 2007 with that seminal paper that came out also from Mayo Clinic looking at the relationship between fibrosis. I've been fortunate to know Dick Eman for a long time, and that was around the time that my lab was developing PDFF around 2005, 2006. Right around when 2007 and MRE came out, I was lucky to be able to collaborate with Dr. Eman, and we were able to obtain a prototype instrument. So we've been doing MRE for about 15 years now at the University of Wisconsin. So we've had a chance to learn a lot about the ups and downs of it. Just briefly, for those of you who are not familiar with MRE, it's very similar to MRI. The main difference is that it does require a driver device that is essentially a plastic paddle that is placed in the right upper quadrant, and it's just secured with a neoprene wrap, and then it's connected by a tube that goes outside of the magnet that is essentially connected to a subwoofer that puts in vibrations at about 60 hertz. So it sort of jiggles your right upper quadrant. I've had that done myself several times. It's really not that uncomfortable, and the machine just gives sort of a gentle vibration to the rib cage, which transmits shear waves into the liver. What it does is it synchronizes that with the scanner and uses motion sensitizing imaging methods that create wave images that you can watch propagate through the liver and then the scanner essentially is able to figure out how stiff the tissue is from that. And then that's where the work has been done, correlating the stiffness to levels of fibrosis. It just takes a couple of breath holds. It depends on the specific technique. The original techniques were about 4 breath holds. You can do it in about 1 breath hold right now. So it's actually quite fast. The longest it takes is just the setup time, which is just a couple of minutes just to get it secured quickly. So the whole thing can be done in less than 5 minutes. And then typically we also want to add proton density fat fraction, PDFF, to this as well, which is also a 20-second breath hold. So you can be in and out of the magnet with both an MRE Elastogram and PDFF, which we almost always do together in less than about 10 minutes of table time. And so we usually schedule these in about a 15-minute slot. Our original uses for this actually interestingly came from children. Our pediatric hepatologists are reticent to biopsy children with suspected NASH. The way that we started doing this is that when the children underwent anesthesia for their biopsy, we would actually bring them to the MRI suite first, do PDFF and MR Elastography, take them to the interventional suite to do the liver biopsy, which was great because we learned a lot that way because we could correlate the biopsy findings with MR Elastography. And no surprise, we found really terrific concordance. And then what we would do is, as the patients were being treated, we would use the imaging only to track the patient. So if a liver is stiff, it's abnormal. And as the stiffness went down and the PDFF went down, we knew that the patient was going in the right direction. And that also correlated well with serum markers as well. Other applications that we found quite quickly were actually with Harvoni therapy for hepatitis C, which, as you know, at least early on, was a very expensive treatment. And patients weren't eligible for insurance coverage unless they had F2 fibrosis at least. So I actually got to know our pharmacists quite well, and they wanted to have the most accurate but non-invasive method for detecting fibrosis. And so I learned a lot about Harvoni therapy and hepatitis C, and we used that as determining whether the patients would be eligible. And then there's a number of other applications as well, including acute alcoholic steatohepatitis in some of our patients and tracking therapy that way. But really where we're gaining traction is in suspected NASH and really determining whether or not the hepatologists want to send the patients to biopsy or not. And then finally, the other major protocol where we're using it is part of liver donor workups. We have a well-established liver transplant program at Wisconsin, and we've been having increasing reliance on liver donors. And just given the prevalence of NAFLD NASH, we would like to be able to identify those patients without even having to do a biopsy if necessary. And if there's a question, the patients will go to biopsy if they do proceed for partial hepatectomy for donation. But that's been another major application. One of the questions that comes up a lot is the cost issue, which is a really interesting issue. And we could talk for hours about that, and I won't. But as Mazen alluded to, this is something that we've thought a lot about. And I think there's a lot of confusion about the issue of cost. And there's a lot of different ways of looking at it. One way to look at it is what the insurance pays. And I think a good metric of that is looking at Medicare costs. We have a few different protocols. One, we have what we call a rapid fat iron protocol, which we use the methods that we use for PDFF. Also, we can quantify liver iron too, and we can talk about that later. So in one breath hold, we can get liver fat and liver iron concentration, LIC. What we've been charging for that is an MRI abdomen without contrast with a limited 52 modifier, which is basically about half the price of a regular non-contrast MRI. And it turns out the cost for that is about the same as an ultrasound. So PDFF and LIC are about the same cost as an ultrasound. And then about 3 or 4 years ago, there was actually a new CPT code for elastography as well. That cost is a little bit more, but not a lot. Medicare cost is under $300, a total technical and professional fee to do an elastography. And so we have dedicated protocols where we do elastography and we also do PDFF at the same time, and we charge for a PDFF. So that's just a little bit more expensive than an ultrasound, but that gives you an idea. The only other piece of this that is a slight complication, PDFF can be used as the regular scanner with just software in order to acquire the images and reconstruct the images. Elastography does require the additional driver equipment, which does add to the capital cost somewhat, and it means that you have to have this on any scanner that you want to do it on. But we actually have this on all of our scanners at Wisconsin, and so from our point of view, access is exactly the same. That may not be true at your local institution, so you want to know how many scanners and which scanners have elastography. And then the last point I'll make is that elastography and PDFF work great at both 1.5 Tesla and 3T, and those are the two main field strengths that are ubiquitous within most modern clinical practices.
We do it the same way that Scott's Place do it. I made up a name, we call it MREFF to abbreviate it, which means MR Elastography and fat fraction at the same time. So we get both of them done on a lot of patients.
And thank you for lending a 5-letter acronym to our podcast and lives. There aren't enough good 5-letter acronyms running around. So that was in its own a contribution in addition addition to the practical content of what you did. And Kay, what I was hoping you'll talk a little bit about is some of the, Scott diving into the economics is a good start, but some of the practicalities of availability and access and other things that people should understand about utilization. So your floor.
Yeah, absolutely. As we've heard already this morning, MRE is a fantastic non-invasive tool, and MREFF is already used widely in clinical practice. So we're waiting for clinical trials really to catch up on this. The goal has always been to replace liver biopsy for fibrosis assessment and really improve clinical care for these patients. We've been really thrilled with the adoption so far. MRE is actually quite widely available. There's approximately 2,000 MRI scanners globally that have MRE available, 1,000 of those in the US. We estimate that in about 95% of NAFLD patients living in the US are within a 1-hour drive of MRE. So if MRE is not available at your institution, ask for it. Like Scott said, most radiology practices want to be responsive to clinician requests. And for new or existing MRI scanners, adding the MRE application isn't challenging and should cost less than purchasing other non-invasive devices such as FibroScan. And for the actual exam, we've already talked about this, but if the clinician orders just an MRE and PDFF or MREFF, this is a low-cost rapid exam. And based on the 2019 CMS data here in the US, the cost can be around $170. So MRE can be cost-effective. In the 2020 paper by Villar Gomez in Clinical Gastroenterology and Hepatology, FIB4 plus MRE was the most accurate non-invasive test for the detection of cirrhosis and was only marginally more expensive than FIB4 plus VCTE. That kind of gets into the adding MRE to the scanner and both ordering it for patients. But on the research side, I think I want to highlight a few things that it's been a really great year for MRE. It's exciting to hear about Mazen's work on MAST, as well as MeFib from UCSD, and both combining Mazen and Alina Allen's work demonstrating liver stiffness can predict clinical outcomes, both in cirrhotic and non-cirrhotic NASH. These are really important papers that will help accumulate the evidence needed for regulators to accept these imaging tests as trial endpoints. We hear they're already used in clinical practice. It's time for clinical trials to catch up. We'd hopefully replace biopsy eventually with these NITs using MRE and PDFF together. We're there. We're very close.
Kay, thanks. That's great. Stephen, I'm looking at you. I'm flashing back to NASH-TAG and Kay's comment about we're very close. And I would love for you to comment a little bit about how close and where you feel we are close and where you feel we got to get to.
Yeah, I think with anything, the FDA is driven by data. We are accumulating a large body of data with MR Elastography, particularly as it pertains to the diagnosis of the at-risk NASH patient, those people that are likely to need pharmacotherapy to help them. And in parallel, we have drug development rapidly moving forward such that we potentially will have our first FDA-approved drug, if not this year, then next year. So in parallel with drug development, we have non-invasive testing development, and I think MRE has really taken a huge step forward here, particularly with that context of use of diagnosing the at-risk NASH patient. The other context of use that I really like about MR Elastography is its ability to predict long-term outcomes. This is exactly what the FDA wants to see. What we need to do is take a closer look at all of the data that's been done to date with MRE and outcomes and really summarize that in a very succinct way for the agency and for the field so that we can generate the groundswell of not only academic enthusiasm for this, but also patient-level enthusiasm and provider-level enthusiasm and, quite frankly, lawmaker enthusiasm to drive the FDA to hopefully change to a non-invasive test. What we got out of NASH-TAG was a willingness of the FDA to listen and look at the data and see where we are relative to changing to an NIT. And I'm hopeful that that'll happen. The one area where I would like to ask Kay and maybe Scott a little about is really the other context of use. So I think of non-invasive tests with three contexts of use: the diagnosis of the patient with at-risk NASH, the long-term outcomes, and then second, as Mazen alluded to, predicting response to therapeutic intervention. And what I know about MR elastography is that we're really good at identifying when MRE is worsening, that's linking to worsening of underlying liver disease. And we talk about 15%, maybe 20% worsening of MR elastography. And I think that gets us over the coefficient of variance of MR elastography and predicting that outcome. But what I would like to ask you is, do we have any clear data on improving MRE and what threshold we have to do to link to improvement in underlying NASH or fibrosis? And are we to the point where we can say, if you improve your MRE by X, we can reduce outcomes? difference?
I think the answer is that there is a lack of data in that area, and that what we do understand very well is the cross-sectional correlation between stiffness and other related biomarkers that you can derive from MRE with the histology. But to actually look at the outcomes themselves is an area, especially for things like weight loss surgery, and how does that correlate with the change. Cross-sectionally, it's understand at the beginning of a study and at the end of the study, but to actually look at the change. And that is an area that more data are being acquired. Claude Serlin and myself have an NIH grant actually looking at that exact question based on that exact gap that you've identified. But, Kay may have more insight to that from the clinical trials perspective as well.
Yeah, no, I actually agree completely with Scott. I'd put the question back on you, Stephen, and say, how many studies have we actually seen fibrosis improvement? So MRE is a fibrosis biomarker. We need to see some movement of the needle in fibrosis before we're going to see improvement in MRE. So we just need to combine those studies, use MRE as a biomarker, and have some positive improvement on fibrosis in patients, whether that's weight loss or some pharmacologic intervention. We just haven't had that ideal combination of a treatment that works and MRE used as a biomarker to really acquire that data.
So let me turn that around one more time to you, Kay, because I think this is where MRE actually has the upper hand on liver biopsy. I think it is much better at holistically telling me what's going on within all the different segments of the liver. Right? We know that fibrosis is heterogeneous, and so I think MRE is better. So to your point, we do need to show that our drugs are moving the needle histopathologically, but I would challenge that a bit to say I think we have shown that, at least with our non-invasive test, linking to fibrosis improvement. And we saw early data movement with aldafermin and more recently with efruxifermin and FGF21. And quite frankly, with the press release out with 89bio and their FGF21 as well. Lanifibranor, we don't have MR Elastography data with that drug, but there is an opportunity here as we move into 2022 to really begin to understand this context of use around measuring therapeutic efficacy. We have soon top-line data from the Maestro-NAFLD-1 trial in over 1,200 patients where MRE was done with 80 and 100 milligrams of drug. We'll have that data to mine. We'll also have the Maestro-NASH trial, which should read out this year in around 1,000 patients with paired liver biopsy treated for 1 year with resmetirom, and MRE included in that analysis set as well. This year, we'll answer a lot of questions around that context of use, and I'm hopeful that we'll be able to knock it out of the ballpark and actually identify very specifically, at least with this particular mechanism. And I think that's another feather potentially in the cap of MRE, is that it may be agnostic to mechanism, whereas PDFF is more likely to be mechanism specific.
Can I add to that? I totally agree with what Stephen said. What I'm going to say is controversial, and maybe we can talk offline with Kay and Scott, but I do think that MRE is probably improving on some of these studies, but we're not seeing it. Sounds mysterious and vague, I know, but there should be an adjustment for change in liver volume with the changes on MRE. I don't know what's the exact secret recipe, but as you know, like before, they said, well, there was that concept that if you lose fat, your MRE is getting worse. That some trials, maybe like there were rumors about that. I think it's a proportional thing to the liver volume, and we need someone with Scott and K brains to figure that out, how we can take the volume change into consideration and go beyond that to show the MRE changes.
Well, I can comment on a few things there. There's a lot of things in there to unpack from both what you just said, Mazen and Stephen. I'd love to hear Kay's thoughts on that as well. But I mean, one of the cool and profound things about imaging is that it's really the only way to evaluate an entire organ short of doing an autopsy. The fact that you can look at the whole disease process over the entire organ is really amazing. And you can do that with both PDFF and MRE. This is probably one of the fundamental reasons why the coefficient of variability is so much better with imaging than it is with biopsy, because you're getting the whole organ as opposed to 1/50,000th of the sample. It's really unfair in many ways to the pathologist. So I fully get that. That's really where we've already seen studies showing where imaging biomarkers are showing a treatment effect. For example, some of the work that Rohit Lumba has done with PDFF, where you don't see any change with biopsy, it's probably just due to that coefficient of variability. Another area that's going to be very exciting and is going to help workflow and accuracy and standardization is artificial intelligence as well. So we have standardized or more automated reporting. And Mazen, that gets to your last point, is that especially with these volumetric imaging methods like MRE, you can segment the whole liver very easily. And now we're almost there, but I predict within 6 to 12 months, we're going to have automated volume measurements of the liver. And then you could ask those questions and see whether we need to normalize or correct for volume, or just simply look at liver volume, like accurate liver volume as a biomarker in itself, which would be a really easy one and interesting one to look at. I don't know what Kate thinks.
Hey, Scott, let me just foot stomp what you said about the amount of liver tissue we look at with a biopsy. You mentioned 150,000th, which it's actually a lot less than that.
Okay.
You're taking a core piece of tissue out, but you're only looking at about 1/14th of that core piece of liver. So it's really about 1/700,000th of the liver rather than 150,000th, just for perspective.
The liver volume, it's kind of a new and old topic at the same time, and we have been looking at it, but larger liver means you're probably getting some resistance to the flow. We have seen recently people looking at the spleen volume. We know that spleen gets enlarged without full fibrosis or F3 in fatty liver. We know that it changes with treatment, that the spleen volume can shrink. So I would imagine that is related to the liver volume as well. So there is a story in the liver volume that makes it just more exciting and more open area for research, and compared just to, PDFF and MRE reading only as a linear or continuous measure versus looking at the volume and correlating or adding them to each other or correcting them. It's above my head, but I think the hepatologists and radiologists maybe need to talk about it.
So, Mazen, first of all, it's above your head. I can't even imagine where it is in relationship to mine. But yeah, that's about right. Way over the ceiling. So, Stephen, as you were talking about 700,000th of the liver, I was thinking about needle in a haystack, and that brought me back to the last time we talked on this podcast about looking for needle in a haystack, which is balloon hepatocytes. If, in fact, it takes you 80,000 cells to find one balloon hepatocyte that 9 pathologists can agree on, which is Quentin's work, and you're only looking at 1/700,000th of the liver here, then it seems to me that the odds of finding a balloon hepatocyte in a biopsy, I can't quite get the math on this, but it's infinitesimal is the phrase that comes to mind, and that might be an overstatement.
This is exactly why we need to move beyond the biopsy, and why the whole conversation we've had here is about the holistic view that this image analysis gives us relative to the disease state. And at the end of the day, any injury to the liver results in a scab in the liver. It results in fibrosis in the liver. If we have a tool that's very good at measuring this scar in the liver, then at the end of the day, do we really need to measure the amount of ballooned hepatocytes in the liver? We have been so in the weeds on this thing. It's time to step back to 30,000 feet, realize what we're looking at, and it's all about outcomes. We've already shown that MRE can predict outcomes. At the end of the day, that's what we should focus on. That's really where the utilization of this tool is going to be brought to bear, in my opinion.
Okay, great. So I'm going to ask Louise I've already made my off-the-wall comment, so I'm going to ask Louise for hers, which will hopefully be a lot closer to the wall or the ceiling than mine. And then I'm going to ask on a final go-around for each of you to talk about, if you were not a researcher per se, but a practicing hepatologist trying to figure out, what would you be doing with MRE today based on the data available, the access to equipment, the reimbursement, all that? And what trends would you look for over the next year to tell you it was time to step it up? But let me start with, that's so everyone's prepared. Louise, comments, thoughts?
Louise Campbell.
I had a number of comments or thoughts during it that were quite exciting, in the fact that I personally see MRE as the one diagnostic that is going to move us beyond the biopsy, in the relationship that it's whole, as we've discussed, of the liver. Can I just ask, the FDA at NASH-TAG were fairly keen on more data in comparison to biopsy. Is there any data looking at a biopsy, AI read, and then MRE, and which one is picking up the changes in the liver more accurately? Because we must, by the sound of all of the trials that you've referenced there, have enough biopsies to look at where the changes are, how AI is interpreting the biopsy, and how AI interprets it to MRE. Because if we can establish that MRE and AI are a far better predictor than liver biopsy, is that the type of data that gets us to beyond the biopsy?
Let me take a jab at this and see what Kay and Scott know about these data. I don't think there are MRE data compared to AI that published in the public domain. I've heard that there are some more correlating MRE changes with collagen content changes. I don't like to say heard it and spread rumors, but I wanted to see it published and presented. And Steve and I heard it from Elena, but I just don't want to spill the beans, I guess, and just say what it is and how much it is. But there are data being produced to correlate MRE with AI changes. The one thing I want to emphasize, and that's why I jumped to answer first, the FDA actually is not looking at correlation between MRE and liver biopsy. And the FDA has moved the needle now that they are really specific about that MRE or any NIT changes. I assume at the end of the day, it will be a combination of NITs that 2 or 3 will put in a small pot to enter patient in a phase 3 trial and see the changes over time. But for those to make it to the finale or the finish line, the FDA wanted an outcome study or like correlation with outcomes showing that we're not sure yet. Is it prospective data showing NIT lead towards any outcomes, or, which is more difficult to case point because we don't have drugs that improve fibrosis, is it the NIT improvement lead to improving outcome, which is very hard study to do. It takes some time. It needs a smart design, and Litmus and Nimble have contributed significantly to the field of NITs or NITs as some people call it, but it might need additional studies as well to correlate with outcomes. That's expensive. That takes a long time, but Stephen and I were trying to initiate an effort to look at this prospective data of NITs correlating with outcomes. So I just wanted to bring up the FDA point about they're going beyond the biopsy to validate an NIT as a primary efficacy endpoint for registry trials.
And I'll just add, incidentally, Scott, you made a comment very early on about having your own MRE done and that it jiggles the liver. So just parenthetically, in our NASH patients, when we originally send them to MRE, they actually can have some discomfort because the capsule, Glisson's capsule, is stretched. And so if you are set up for intermittent right upper quadrant pain, when you jiggle the liver like that, it actually, we've had patients come back and say, yeah, that hurt. But here's where it gets really cool, because with our drug therapy, where we're removing liver fat and we're shrinking Glisson's capsule, when they go back a second time and they say their liver doesn't hurt anymore, like there's a direct correlation between reduction in liver fat.
Sounds like a sonographic Murphy sign when we push with the ultrasound probe on a gallbladder.
Well, looking at Scott, I don't think he had any pain when that thing was vibrating.
Okay.
Well, I appreciate that.
Okay. So
I just have one more question.
Go ahead, Louise.
Because I think it was Scott that commented on reading iron within the liver, particularly for FibroScan and things like that. We use it said that iron can interfere with the score and the potential stiffness, and therefore you can't read it particularly well. Have you ever seen any correlation between high stiffness and high iron, or with the MRE? Is that able to pick that out so that it could help us in our hemochromatosis patients?
Sure. Well, I'm going to tell you just a very quick, funny story. The very first clinical MRE that I ever did failed miserably, and it was in a patient with, in retrospect, with a serum ferritin of about 10,000 and had iron off the charts. And so in severe, extreme iron overload, MRE can fail. The technical success rate of MRE is well over 95%. So it's very uncommon that it fails, but in these cases it will. So I called my hepatology colleague and said, well, I have good news and bad news. The bad news is that the MRE failed, but the good news is that I gave you a diagnosis that you didn't know. The ferritin was in retrospect. He had severe iron overload and he had unsuspected hemochromatosis. But sure, if it is technically successful and there's fibrosis related to whatever disease process, you'll pick up the stiffness quite well. But with PDFF, actually, this is one thing that people don't talk about, is that you also get liver iron concentration for free, all in the same breath hold as well. So really with the hepatogram that we've been talking about, or the MREFF, we should really call it MREFF LIC, you get stiffness, you get PDFF, and you get liver iron concentration as well.
Scott, I love this story. I think a pathologist heard what's your research up to and chose the patient and sent it to you to do your first MRE.
All right. Closing comments from everybody. Okay. If you're practicing right now, how should you be thinking today, all things considered, FDA, reimbursement, location of machines, state of knowledge? How should you be thinking today about integrating MRE or MREFF or MREFF LIC or all the other alphabet that you put after it? Integrate that into your practice today. And what trends should you be looking for over the next year to tell you it's time to step it up or move in a different, broader direction? Kay, you're nodding, so I'm going to invite you to go first.
I'll preface this with, I'm not that kind of doctor. answer, but I will say that if I were practicing, I would send my patients that I was suspicious for non-alcoholic fatty liver disease to get an MRE and PDFF. Stop asking them to have a biopsy. If we're not suspecting other etiologies of liver disease, we don't need a biopsy for that anymore. Then based on Alina Allen's work, we could have some idea of who's at risk for progression to liver-related events. And I'd call them back if they have high liver stiffness for more monitoring. But otherwise, if they have a low liver stiffness value at baseline, let them go and have them come back in years later. Looking forward, it'd be great if we have a drug approved to treat non-alcoholic fatty liver disease. And instead of screening with biopsy, we could screen with these non-invasive tests, whether that's MRE, PDFF, and some other additional blood tests or what that looks like. But then we could have both identify who could benefit from this treatment and also monitor their response.
That's great, Kay. Thank you so much for that. Stephen, why don't you go next?
I couldn't agree more with Kay. I love the utilization of both PDFF and MR Elastography in my clinical practice. I don't always use it as a first line. I get FibroScans and clinical labs in all of my patients. And remember that with 100 million Americans with fatty liver, about 75 to 80 will grow old with their fatty liver. So we're really targeting the at-risk patients. And this is where I think the world of non-alcoholic fatty liver is beginning to shift and pivot, where we begin to use sequential testing of our NITs to really refine where we need to be with these patients. So for me, if I have a flag, if I have an indeterminate value or a positive value on my initial testing, those are the people I send forward for MR. It would probably be quicker than that if I had less than an hour round trip for all of my patients. So as we begin to understand how to implement this technology and really get at how good it is, I think all the work you're doing, Kay, in driving the ability of local radiologists to have access and clinicians to have access to this tool will be very, very important. I know from my own clinical practice, I'll have people in San Antonio that live on one side of the city and they're wondering when I'm going to open a clinic on that side of the city so they don't have to drive 30 minutes to come all the way to my clinic. So I can imagine if we could get that time down to 30 minutes rather than 1 hour, I think that would be quite helpful. But it is a tool that is going to continue to revolutionize the field of NASH.
Stephen, thank you. Mazen, Scott, toss a coin. Whoever wants to go next, go next.
MRE is in my practice and PDFF as well. I use it the same way that Stephen uses it. We're not going to jump on it as the first test. I think sequential testing became almost the standard, especially in those that know how to do NASH. My biggest thing is, and I want to thank Journal of Hepatology and their editors, a lot of our patients to get the biopsy in that study had either FibroScan or MRI before getting the biopsy. And they understood that this is now what's happening in clinical practices. I still get these sometimes reviewer here and there that say, well, you did a FibroScan or MRE first before the biopsy, so your cohort is biased. And I want to argue with them. And I say, it's actually unethical now to have just the NASH patients walking into your office and just jump into biopsy. MRI-PDFF, MRE are here to stay. We need further steps to get Kay's, Scott, Stephen, Luis, and Roger wish, and of course my wish to replace liver biopsy in phase 3 trials. I do agree with others that there is more work to be done in a prospective fashion and to show a correlation with outcome. Then the FDA is relieved and we don't have to do liver biopsy in such a large number of patients and have a screen failure with a tremendous number of patients. Many of them, they have disease, but they missed the balloon cell and they did not get enrolled.
Okay, thanks, Mazen. Scott?
Well, I agree with all of these comments, and I would just add a couple of things. First of all, I think the one myth that we all need to get past is this whole myth of MRE being so expensive, and we've talked about that already. That's simply not true anymore. 20 years ago, perhaps, that was the case, and the cost is really on the order of the other non-invasive tests that are being performed. That being said, it still is a precious resource. There are about 2,000 MRE units out there that we know of, but I would add that there are about 25,000 MRI scanners in the United States, and so there's a long way to go in terms of disseminating this technology. There's probably more versions of the PDFF software out there as well, and in fact, it's actually one of the most commonly adopted software on all of the major vendors, and so PDFF is already widely available, and MRE is slightly behind, but it is coming up very quickly. It is a precious resource. We do have to be mindful of it, so what I'd really like to see are are more standardized guidelines. So, for example, within my hepatology group at the University of Wisconsin, there's some heterogeneity about who's ordering what, and the same patient really should go through the same algorithm, in my view, whether it's FibroScan first or ultrasound elastography or MRE elastography, and when to go from one test to another and how exactly that's done. There's a lot of work that needs to be done so that we can use these technologies appropriately.
So, Scott, that's great. And one of the things I'm inferring from what you said, unless you were implying it, which you might have been, is that there's an interplay between how fast the MRE technology diffuses from the 2 to 25 or wherever it winds up, and the need to really be careful about protocols, because protocols have scientific value. They also have practical, logistical value. Scientific value will not change over time, but the logistical value will lessen if more machines were available within Stephen's 20-minute drive of his office as compared to an hour. So one of the things I take from that is that if I were a practitioner, one of the things I would be keeping an eye on is how much technology was available, how close to where I am.
Absolutely. So that matters as well. And guidelines could be if you live in Rochester or Madison, where we have lots of access to MRE elastography, that might be different for a local patient as opposed to one who needs to drive 4 hours from northern Wisconsin or northern Minnesota. So that's very true. But I think the key thing is I'm very enthusiastic about these biomarkers. I think there's a lot of value for all the reasons that we've been talking about, but using it in a thoughtful manner is really what I'm trying to say.
And thank you for that. Louise, anything to add before we wrap it up?
You've got imaging. Have you ever tried doing it with brief intervention with the patients and seeing what the response is? Because patients respond very well to FibroScan because they can see it. And where they can see a difference, they become competitive. And whether or not you've ever looked at the benefit of that in detailing the scan to see whether or not it motivates and it induces behavioral change better.
It's a research study I've certainly always wanted to do, but it's one of those things that's too many projects, not enough time. But I don't know if you've seen the MRE images, but if you have a red liver, it hits you. This is something, red is bad. I've always heard you say if they can see the movement in the FibroScan values, they feel like their weight loss meant something. Showing them your liver went from, well, probably not red to green, but from green to purple, that would be impactful. I agree with you completely. It's something we should look at.
We'll get across the finish line when, those conversations you had at a party of, hey, what's your cholesterol? What's your HDL, your LDL, right? How many times have you had that conversation with your friends? And now it's calcium score for coronary arteries. I think we will have made it when people know their PDFF and their liver stiffness and talk about that at the cocktail parties.
Well, I thought you were going to go all the way to what color is the liver on an MRE. I'm purple, I'm green, I'm red.
Well, it's funny Scott says that because I do this and I do wellness. And when I do groups of guys, they all come out of the room and they compare. Of course, I can't discuss their individual results, but they're chirping around the dinner table. They're talking about, and then when they come in for their next ones, I beat you, I did this. It really does. And guys respond really, really well to data, making it destigmatizes it. Because their comment is, well, why wouldn't I want to know I've got fat in it because I can do something about it? So you're perfectly right. It's an amazing topic conversation because then they all compare their cholesterol level, their statins, their antihypertensives, and their diabetic meds.
And now, back to Roger.
This conversation is sponsored by Resoundent, a Mayo Clinic company and the developers of MR Elastography. MRE is widely available with over 2,000 locations worldwide and can be done as a low-cost rapid exam in just 5 minutes. Together with MRI-PDFF, this quantitative exam is called an hepatogram, a powerful, non-invasive alternative to liver biopsy in many cases. For more information, visit www.resoundant.com on the web. We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next week for a stimulating discussion on advances and implications of single-cell genomics with Professor Scott Friedman and Neil Henderson. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.